rheumatoid arthritis. What's the most likely diagnosis? So the urgent step I would first take in this patient is to do a synovial fluid aspiration for microscopic culture and sensitivity and a gram stain. Others I want to do is the commencement of antibiotics, analgesia, and NSAIDs. I also want to do a joint drainage. The investigations I will do for the synovial fluid MCS, a positive gram stain or a synovial fluid YWC count of greater than 20,000 cells per microliter, mostly neutrophils in the purulent synovial fluid are diagnostic. Paralyzed light from microscopy for crystals. I also want to do a blood culture, a full blood count, a C-reactive protein, an anti-CCP, and a knee X-ray. My differential diagnosis here will be septic arthritis, rheumatoid arthritis, reactive arthritis, pseudo-gout, gouty arthritis. In managing this patient, I want to give ofloxacin 1 gram 6 hourly plus a third generation cephalosporin like ceftriaxone. Then the purulent synovial fluid, the management will be guided by what I get by the gram staining. If it's a gram-positive cocci, I want to give vancomycin, while for gram-negative bacilli, the treatment will be guided by the risk of pseudomonas infection. In case the patient is an immunosuppressed patient or an IV drug user, I want to give a beta-lactam, an aminoglycoside, or a fluoroquinolone. But if the person does not have risk for pseudomonas, I want to give a third generation cephalosporin like ceftriaxone. For gram-negative stain, or the synovial fluid cell count is consistent with septic arthritis. For the immunocompromised patient, I want to give a vancomycin. For the traumatic patient, I want to give vancomycin plus a third generation cephalosporin. For the immunocompromised patient and IV drug user, I want to give the vancomycin plus a cephalosporin with an anti-pseudomonas activity. Example of this is ceftazidime. And in doing the treatment, I want to treat for 6 weeks. I want to give IV for 2 weeks, NSAIDs for analgesic, and I will tell the patient to avoid weight bearing, and I will consult the rheumatologist, the infectious disease consultants, and the orthopedic consultants. Other features of rheumatoid arthritis on X-ray, you will see joint space narrowing, osteophytes, subchondral bone sclerosis, subchondral cyst. Then for the clinical features of rheumatoid arthritis, we have symmetric polyarthritis involving the hands, wrists, elbows, and shoulders, usually sparing the DIP joints. Pain are usually early in the morning with stiffness. Other articular manifestation of rheumatoid arthritis in the eye, episcleritis, in the skin, rheumatoid nose, purples, and someone should another person. Okay, for the respiratory, I'll see pleurisy with effusion, pulmonary fibrosis. For the cardiovascular system, I can see pericarditis, myocarditis, mitral valve disease, and cardiac nose. In the nervous system, person can have carpal tunnel syndrome, monoarthritis multicomplex, and cervical myelopathy. Hematology, you can see anemia, splenomegaly, and lymphadenopathy. The mostly diagnosis in this patient is rheumatoid arthritis with superimposed septic arthritis. Looking at a brief overview of septic arthritis. Septic arthritis of the joints occurs via direct injury or blood-borne infections from an infected skin or lesion or other site. Approximately 2 cases per 100,000 people per year. It's a medical emergency that requires prompt treatment to prevent irreversible joint destruction. It has a significant mortality of up to 10%, reaching 50% in polyarticular sepsis. The risk factors are age greater than 80 years, diabetes mellitus, rheumatoid arthritis, prosthetic joints, recent joint surgery, skin infection, intravenous drug use, alcoholism, prior to intra-articular corticosteroid injections. The organisms are mostly commonly caused by septic arthritis. Commonly caused by septic arthritis is Staphylococcus aureus. Other organisms include streptococcal and other species of Staphylococcus and Neisseria gonorrhea. Hemophilus influenza in children. These are gram-negative organisms in elderly or complicating rheumatoid arthritis. In young and previously fit people, they usually present as hot, red, swollen, painful, and is held immobile by muscle spasm. In the elderly and the immunocompromised, they present with rheumatoid arthritis. The onset may be insidious with no systemic symptoms, and a high index of suspicion is needed. In 20% of patients, the sepsis affects more than one joint. Investigating this patient, the fluid is usually frankly purulent. Aspirate the joint and send the fluid for urgent gram staining and culture. The culture techniques should include those for monococcal and anaerobes. Blood cultures are usually positive. Food blood count. Leukocytosis is usual unless the patient is severely immunosuppressed. Wound, skin swabs, sputum, throat swabs, or urine may be positive and indicative of the source of infection. In managing this patient, treat on the basis of clinical suspicion, probability with subsequent confirmed identity of the organism, local pattern of antibiotic sensitivity, and microbial advice. Therapy should be started immediately before the culture results are available because joint destruction may occur within weeks. The joint should be aspirated and then immobilized initially, followed by early physiotherapy to prevent stiffness and muscle wasting. Intravenous antibiotics should be given for 2 weeks and then oral antibiotics for further 2 to 4 weeks, which is given a total of 6 weeks. Response is monitored clinically and with ESR and C-reactive protein. Empirical treatment of rheumatoid arthritis for suspected gram-positive infections. First-line therapy is vancomycin with clindamycin or cephalosporin second line. For suspected gram-negative infection, the first-line therapy is third-generation cephalosporin with an IV ciprofloxacin second line. In confirmed methicillin-sensitive Staphylococcus aureus, primary options include fluoxacin alone or combined with fluoxetinic acid or gentamicin, while penicillin allergic patients should receive clindamycin or a third-generation cephalosporin. In cases of methicillin-resistant Staphylococcus aureus, vancomycin is the drug of choice. Antibiotics should be altered according to sensitivity results we get. Drainage of the joint and or arthroscopic joints washout are required in all cases. Thank you. These are my references, and I also thanks the part 2 slides that I got online. Thank you.
Oh, thank you so much, Dr. Rabo, for that beautiful presentation. Very detailed, concise, and very lucid. Thank you so much. Okay, so now we'll take comments and questions from the participants first, and let's give it thanks coming on the chat. Okay, so Dr. Ede is saying, thank you so much for the presentation. What if it's a rheumatoid arthritis flare? How will you manage?
For a rheumatoid arthritis flare, I would still want to give the current drugs that the patient is currently taking. I also want to give a corticosteroid to reduce the flare in the patient, and also want to look for the source of the flare. What was the precipitating factor of the flare? If it was an infection, if it's an infection, I want to look for the source of infection, then treat accordingly.
All right, thank you so much. I don't know if you have more comments. on questions. Okay, a lot of thanks to you on the chat. Dr. Laitu Abimbola is saying thank you. Dr. Amadi Idombu saying thanks for the lucid presentation. Dr. Ichi Ujile saying thank you for a wonderful presentation. Dr. Makri Binabo saying thank you for a presentation. Okay, I think it was very straightforward. Sorry, I just want to ask, can osteoarthritis be a differential here too?
Well, it's because of the question actually said warm and hot. So which actually showed that an effective process was going on. But also rheumatoid osteoarthritis can actually be a differential, but I want to put that differential down because of the way the clinical scenario came about.
Okay, thank you so much. Okay, so it was obviously a beautiful presentation. No more comments. I can't see any. Okay, Dr. Mohammed Sani, please go ahead.
Thank you very much for that presentation. I was a bit skeptical when she mentioned empiric treatment for septic arthritis with vancomycin in the first line. I wanted to ask two questions before maybe I pass my comment. First is it in culture negative or culture positive septic arthritis? Then two, that means in the culture positive septic arthritis, are you still going to go ahead with vancomycin without any other clinical input or relevance? So those are my two questions.
For the gram-positive, the first-line treatment is vancomycin with a clindamycin or a cephalosporin as a second line. While for the negative, it's a third-generation cephalosporin with IV ciprofloxacin with the IV ciprofloxacin second line, sir. That's what I saw, sir.
So is this for this is for empiric therapy yet?
Yes, until
okay.
we obviously wait for the culture and the results of the culture and sensitivity, then we'll now treat specifically. But empirically, we have to start treating before the results come in. You can't allow the patient wait because it can be destruction of the bones can occur within these 2 weeks.
Okay.
Okay, it's okay, but I think that one was probably a previous guideline they're employing. Currently, putting vancomycin, you have to put a lot of things into consideration before you commence patient, unless you're thinking of MRSA in the first place. If you're not thinking of MRSA in the first place, straightforward oxacillin, nafcillin, local oxacillin is okay. So unless the patient is at risk of acquiring MRSA, which there are some categories of patients that this patient are at risk of having MRSA, previous hospitalization, recurrent intravenous device administration, and the rest. These are the ones that you think about placing on vancomycin. But straightforward, gram-positive coca and gram-stain in a patient that have septic arthritis, I think you should consider first the MSSA agent rather than MRSA agent. And two, you can combine it actually with as you mentioned, clindamycin or maybe a cephalosporin with clindamycin, which suffices. And that is usually the usual combination. Empirically, you see a patient usually starting on the cellular inhibitors, ceftriaxone, beta-lactam, and probably the protein synthesis inhibitors, clindamycin. That one suffices. Then alternatively, if patient's MRSA, that's when you think about vancomycin. For bigger centers, that's what is expected if you can start with vancomycin. But I think here you have a lot of limitation, and usually toxicity issues, even therapeutic level monitoring is difficult with vancomycin. That is the catch. You may not be able to know when this patient may have toxicity. Probably monitoring drug level is very important in vancomycin. So those are my That's why I say, let me ask this question. Probably if you're in exam, I think you better mention ceftriaxone, probably with clindamycin. Or if you're thinking of MSSA, mention oxacillin, nafcillin. Then if there's resistance to, if you have MRSA, then you can combine vancomycin with ceftriaxone.
Okay, sir, if I got you right, for the first line therapy empirically, we should combine ceftriaxone with the vancomycin. Yes. Okay, thank you very much. Thank you very much.
Especially if you're thinking of even if you're thinking of gram-positive cocci, you're thinking even of staph. Staph can either be MSSA or MRSA. So if you give vancomycin, you've already narrowed it down to what MRSA, and you're limiting the coverage. But if you give oxacillin, nafcillin, and monitor the reaction until you see sensitivity, that's giving you an open window. And you can continue with ceftriaxone and clindamycin for a duration of your treatment and see whether the patient responds or not. Because you have to remember, you may even go back and still do your culture again. It may be culture negative in the initial phase or culture positive in the initial phase. Later, it may be culture negative. So that's what I'm trying to mention. Because if you look at your last bullet, you say in case of methicillin-resistant Staph aureus, vancomycin is the drug of choice. But even in your first slide, you say vancomycin. Do you understand? So that's what I'm trying to draw attention. It should be your MSSA you should cover first while you await it for whether it's MRSA, because there are some drug sensitivity tests you can do to know whether it's MRSA or not. By the time you even see cefoxitin resistance, it tells you that definitely this one is likely going to be what MRSA. So you just stop your other agent and you can add on your vancomycin later on.
Okay, Chief. Thank you, Chief.
All right, thank you so much, Dr. Sani, for that add-on. Points noted. Thank you so much. Okay, so we have a few more comments on the chat. Dr. Bifiri had says, thank you, wonderful presentation. Dr. Olajumoke Ojimi. And Dr. Adiboka says, thank you for your excellent presentation. Ultrasound scan of the knee can be done. Okay, then comment on your choice of antibiotics. I think that has been addressed. Dr. Modu Jafaro says, thanks so much. Can you explain the following associations with rheumatoid arthritis? Kaplan, Sjogren, and Felty syndrome. Okay, Chief, go ahead.
I did not look that one up. I did not look at that one up. I won't be
Okay. So Dr. Okuti Atta says, thank you for a lucid presentation. You can add rifampin to prosthetic septic arthritis to your MRSA and MSSA organism-related antibiotics. Okay, thanks, Chief, for that add-on. Okay, so I don't know if we have any more comments, or if somebody wants to make a comment on the previous questions. Okay, I can't see any other hands up. Okay, so I'll hand over to our teachers. Mark Seven.
Oh, thank you so much. Thank you, Dr. Raboto. Thank you so much. And Dr. Ekele, thank you. I must appreciate Dr. Mustafa Sani for coming in to give his expert opinion on the discussion. Thank you so much. Always appreciate expert opinion, each of these topics. Thank you. The presenter did already, and with the contribution from Dr. Sani, there's no add-on for me. I don't know if any of our teachers, they had to go ahead, please. So they had to. I thought I had to. You can go ahead.
Thank you. Thank you for the presentation. Thank you, Dr. Muhammad Sani, for the addition. I think the other thing to mention is the fact that if the organism is methicillin sensitive, so vancomycin is not also as effective as the other antibiotics like cloxacillin and cephalosporin. So it's always better to be sure it is methicillin resistant before we try to give vancomycin. In addition to what Dr. Muhammad Sani said, so even the efficacy of vancomycin is less when it comes to methicillin sensitive organism than beta-lactams. Beta-lactams and penicillins are more effective than the vancomycin. Thank you very much.
Dr. Ehele, it seems Chief Christabel is not, maybe her network is not too good. You can proceed, please.
Okay, thank you, ma.
Fatima.
Thank you, ma.
Dr. Ekele, go ahead, please.
Okay, ma. Thank you, ma. Okay, Dr. Rabo, please, you cannot share. Dr. Owa, please can share your slide. Dr. Owa, please go ahead.
Yeah, good morning, everyone. I'm trying to do that.
All right, thank you.
It's taking me somewhere. Sure, if I can.
Chief, if you're having issues, you can send the slide to the group.
Okay, let me just send it. Okay, I've sent it to the group, Dr. Ekele.
All right, thank you so much. Dr. Wadu, please can you go share?
Okay.
Okay, thank you, sir. Thank you, sir.
Okay, can I go on?
Okay, Dr. Owa, you have the floor.
Good morning, my teachers and fellow contestants. I'm answering question 5B of April 2022. And the question says, 50-year-old man with typical MI and blood pressure of 80-50 millimeters of mercury for about 2 hours, despite ionotropes. His EACR was normal. He had a CT angiogram done and subsequently noticed cold extremities, bluish discoloration of his toes, and some skin rashes. Also noticed to have low blood pressure and tachycardia. 3 days after the procedure, his urea level went up to 10 millimole per liter and creatinine rose to 200 micromole per liter. Urine microscopy showed granular casts, and renal ultrasound scan showed multiple hypoechoic areas. I have some disclaimer here. I am not sure if this question maybe is properly recalled, because it fits actually like two important diagnoses here. However, I took one, and then I will welcome the contribution of my respected teachers and contestant here. So the first question says, what is your diagnosis? So with that, actually my diagnosis is atheroembolic kidney disease. However, alternatively, it could be contrast-induced nephropathy. And the reason I took the atheroembolic kidney disease is because of the fact that this man already has myocardial infarction, so definitely he must have some atheromatous plaques. And then he, of course, there was an angiogram that they said he was done, CT angio. So I'm not very sure if actually in the exam is conventional angiogram or CT angio. So if it is conventional angiography that maybe he has had, probably there is some of catheterization, which could increase the risk of him developing this atheroembolic kidney disease. And also the distinctive findings of bluish toes and skin rashes that are there, which typically fit the diagnosis of atheroembolic kidney disease, as opposed to cholesterol emboli. Though 3 days are given, but in an acute form of atheroembolic kidney disease, actually he can develop such within 3 days. And presence also of multiple hypoechoic areas on renal ultrasound, which might represent areas of infarct in the kidney. So with these reasons, I took the atheroembolic kidney disease as my most specific diagnosis here. So next slide. So what are the risk factors or causes of the disease? So generally, the atheroembolic renal disease occurs in patients with systemic generalized atherosclerosis. So risk factors include old age, male gender, diabetes, hypertension, hyperlipidemia, and smoking. Next slide. Next slide, sir. Yeah, what test will you do? Okay. What test will you do further to investigate? So in this case, to investigate and probably confirm my diagnosis, I will do renal biopsy, which will show me elongated biconvex needle-shaped clefts, which are some areas that were originally lodged by the cholesterol emboli, and then the cholesterol get dissolved during tissue preparation and leave those ghost cells. Also, if skin lesions are there, like in this case, biopsy of the skin lesions, either the rhabdomyolytic or digital infarcts might be a more simple and less invasive way of making the diagnosis. Of course, other investigation could be eosinophilia, which is very suggestive of atheroembolic renal disease. Others that are not specific are eosinophiluria, elevated C-reactive protein, and then hypocomplementemia. Next slide. To outline principles of its management, actually there is no specific therapy for atheroembolic renal disease. So treatment is involved either treatment of embolic source if it is possible, probably if it is identifiable, and then to treat the embolic source, and then supportive measures of monitoring the UNE, and then electrolyte and fluid management, including renal replacement therapy if the kidney function does not improve with time, and then also modification of risk factors, hypertension, DM, hyperlipidemia, cessation of smoking, and good nutrition. So how will you prevent this condition? Next slide. Yeah. So to prevent is to treat cardiovascular risk factors and minimize invasive vascular procedures as much as possible. And then cautious use of anticoagulants and thrombolytics. And then if at all a certain procedure has to be done with some catheterization, then use of distal protective vascular devices in interventional procedures. And this will prevent embolic material from lodging in the distal sites. What do you give the patient when he is stable? I'll give this patient statin as a secondary prevention against some more new showers of arterioemboli that can destabilize the plaque. So a little on arterioembolic renal disease, I'll discuss it briefly based on this outline. By way of introduction, it is also known as cholesterol arterioembolic renal disease, and it refers to occlusion of renal arterioles by cholesterol emboli from ulcerated plaques, and is part of the systemic arterioembolism disease. And the kidneys are the frequent targets for cholesterol emboli, and this is because of their close proximity to the abdominal aorta and then their associated high blood flow, and making them target in up to 74% of cases. It occurs in patients with systemic generalized arteriosclerosis. Next slide, please. Yeah, and risk factors include old age, hypertension, diabetes, hyperlipidemia, and smoking. And these patients usually have coronary artery disease, CVDs, or other similar atherosclerotic diseases. And incidence is between 1% and 5%. And mostly, these patients tend to be older, with about 60% of them at the age of 70 or more. Next slide. So etiology is that of rupture of atherosclerotic plaque, which may follow surgical procedures like coronary artery bypass grafting, coronary stenting, and angiography being the most common cause of such condition. However, the release of cholesterol emboli also into circulation may occur spontaneously without any procedure. Also, anticoagulants and thrombolytics can be cause of embolization. So there are three types of arterioembolic renal disease. The acute form that develops immediately or a few days after the inciting event. And in this case, creatinine rise follows immediately, after a few days of the inciting event, while this acute form is as a result of recurrent embolization or endothelial inflammation that follows the initial ischemic insult, and which result in further vessel occlusion. And this is the most commonly found type, and the rise in creatinine occurs days to weeks after the initial insult. And the third form is the chronic one with slowly progressive impairment of renal function, and it's often mistaken for nephrosclerosis or ischemic nephropathy. Next slide. So pathophysiology, just a summary of it, the exact mechanism underlying AERD is not fully known. However, some factors play some vital role, like local tissue necrosis and inflammation, activation of renin-angiotensin-aldosterone system, and complement activation. Next slide. And clinical features are usually part of generalized arterioembolic disease, and the commonly affected sites are the skin. In fact, skin is the most common extrarenal organs that are affected, and findings like livedo reticularis, blue toe syndrome, and purpura are commonly seen. Also, because it's systemic embolization, it can involve the CNS with typical features representative of that system. Also, nausea and vomiting, abdominal pain can be because of involvement of the GIT, pancreatitis, and other related symptoms of pancreatitis can also be seen. It presents with acute, subacute, or chronic renal failure, mild to moderate proteinuria, hematuria, accelerated hypertension, or new onset of hypertension. Also, there could be some constitutional symptoms of fever, weight loss, fatigue, and anorexia. Next slide. Next slide. Can I be heard, please? Next slide.
I can hear you. Okay.
Okay, so for investigation, before investigation, I want to say that I tried of in the presence of risk factors. So I tried of inciting or triggering events, acute or subacute renal failure, and signs of peripheral emboli actually suggest the diagnosis. And in this situation, you might not need renal biopsy. So if these are present, the diagnosis is already made. However, renal biopsy may be requested in some cases to exclude things like vasculitis, acute tubular necrosis, allergic interstitial nephritis, and that may provide definitive diagnosis. And if there are skin lesions, like in our index case, like digital infarcts or livido reticularis, or there is a muscle damage, if it is present and can be identified. So skin or muscle biopsy are easier and minimally invasive way to actually establish the diagnosis. Renal ultrasound scan can be done, which can show hypoechoic areas like in our patient. And eosinophilia is very suggestive, seen in up to 80% of cases of arterioembolic renal disease. Other non-specific findings are eosinophiluria, elevated C-reactive protein, and hypocomplementemia. These are not sensitive, nor are they specific for ARD. Next slide. So treatment, like we said, no specific therapy for arterioembolic renal disease. So treatment mostly symptomatic and supportive. So you need to do modification of risk factors. If need be, renal replacement therapy, and you administer statins. Use of corticosteroid is actually controversial. Some the outcome, while some discourage the use of corticosteroid. So my differentials are contrast-induced nephropathy, systemic vasculitis, subacute bacterial endocarditis, and the chronic form of the condition actually mimic hypertensive nephrosclerosis or ischemic nephropathy. Next slide. Complications are irreversible organ damage, end-stage renal disease, visceral ischemia, and membranous nephropathy. Next slide. So prognosis is very poor. It's associated with an irreversible organ damage, and the renal outcome varies actually, with some patients requiring maintenance dialysis, while others improving, but with variable degree of residual chronic kidney impairment. Renal function may improve in approximately 1/3 of patients after a variable time without further embolic events. Thank you.
Oh, thank you so much, Dr. Owa, for that beautiful presentation. Very detailed. Okay, so now we'll take comments and questions from the participants first. Okay, Dr. Mahmoud is sharing some pictures. And then he's asking, thanks so much. Would you give antithrombotic drugs?
Yes, ma'am.
Hello, sorry?
Did you hear me?
Yes, I can hear you.
Would you give antithrombotic drugs?
Yes, some aspirin, not antithrombotic, antiplatelets like aspirins can be given in arterioembolic renal disease.
Okay, thank you so much. I don't know if I have more comments.
So I'm not sure if actually, please, I'm asking if this is supposed to be answered as arterioembolic renal disease or actually contrast nephropathy, because the scenario fits more like arterioembolic renal disease. However, some of the questions that follow like fit more of a contrast nephropathy. So I'm actually not very sure of whether it's actually correct or not.
Okay, I don't know if I have nephrologists in the house. Let's make a comment on that.
Actually, I think we've attempted this question before, and it was arterioembolic kidney disease. We went to it. This question has
Okay.
been attempted. That's what we went to it. Thank you.
Thank you so much. Because actually, when I saw the question too, I was like confused. Should it be contrast-induced nephropathy or cholesterol embolism? Okay, thank you. Okay, so any more comments? Okay, in absence of any more comments, I'll hand over to our teachers. Thank you so much. It was actually straightforward.
Thank you.
Mark Christabel.
Hello. Thank you so much. Thank you so much, the presenter. That was wonderful. I don't know if any of our teachers have any comments. Any comments from our teachers, Chief Chitu, Chief Remigus? We've attempted this before, by the way, so I think like two times already, if I'm not wrong. So, but I don't need any comments still.
Okay, Dr. Yusuf just dropped a question on the chat. I don't know if Dr. I can just take it.
Okay, what is that?
Please go ahead.
Okay, so is there any difference between arterioembolic renal disease or cholesterol embolization syndrome?
Okay, I think cholesterol embolization syndrome is the general thing that happens, which can involve arterioembolic renal disease plus involvement of other systems. So like cholesterol embolization syndrome is the umbrella term where arterioembolic renal disease could be part of what is happening in the syndrome. I don't know. Was I had?
Yes, you are. Thank you so much.
Okay, thank you.
Okay. Because I was thinking they are the same thing.
Oh, okay.
Thank you. Okay, Ma, please go ahead.
Hello?
Yes, Ma.
Okay. I don't know if any of our teachers have any comments. Any comment from our teachers? We have a full house today. Any comments? Okay. Same, everybody's good with home and dry. So thank you once again. Thank you once again for a wonderful presentation. Most appreciate the presenter. Thank you. Dr. Awa?
Yes, ma.
I don't know why the answer was confusing to you. When you saw that blue tool, most likely, you understand. Just know that this
Yes,
is cholesterol embolism. Just in case it's repeated, that blue tool those blue tools just gave it away. So thank you so much. We really appreciate you. Thank you. I think this time we
yes,
have. I doubt if we're able to take another question. So.
We can't hear Chief Christabel. Dr. Ekele, there's a question on the chat box.
All right, Pa. Okay. From Dr. Jamila Bashir. It says, thanks for the wonderful presentation, Dr. Orwell. Please, can you shed more light on the distal protective devices you mentioned? Also, I want you to explain how anticoagulation and thrombolysis can cause the embolism. Thank you.
Okay, thank you. For the device, actually, I don't know how they work, but I feel probably there is a mechanism that during the procedure of catheterization, maybe whatever it's dislodged can actually be collected in such a device and prevent it from moving distally. How it works, I don't know. I have never seen that. But for the thrombolytics and anticoagulation, I think what happens is if the thrombotic plaque is there, sometimes there will be some protective thrombotic thing that can form over the surface of the plaque, which can prevent exposure of the lipid-rich content with the blood. But now, when there is administration of thrombolysis or anticoagulation, this can prevent the development of that protective thrombin, and then also predispose the development of the embolization.
Okay, thank you. Okay, and Dr. Ede dropped a comment on the chat also. She's saying they are both terms are the same. I think she's responding to Dr. Yusuf's question. Is there any difference between arterioembolic renal disease or cholesterol embolization syndrome? Okay, she thinks they're the same.
Okay,
So.
thank you very much.
Okay, so
Dr. Kale, thank you. I think we're done.
Yes, ma, we're done now. We're done.
Presentation.
We're done.
Dr. Awa, thank you. Hope I can be heard.
Yes, ma, I can hear you.
Okay, Dr. Awa, thank you. I appreciate you. Dr. Kale, once again, I appreciate you. Thank you so much. So, I want to please our teachers, let me quickly do the needful.